Welcome, everybody. This is our 8th meeting, and we're going to hear from Audrey Thurm and Beth Potter today and wrap it all up with a presentation from Jacob. And so I will get started, but first I wanted to share a cute picture of some of our kiddos, and there were more. This is a little video, a 30-second video that was up in Times Square on a huge screen and was just the best part of this week. Just the very best part. We all came outside and looked up and just kind of everybody choked up, and it was really cool. Really cool to see creatine deficiencies and those words and images and just, so we had a great experience, and I think hopefully kicked off something really special. So stay tuned for that. Today, we'll hear about the Vigilance study and also the literature review that is part of this project. And then, like I mentioned, wrap up with the presentation from Jacob. So I will go on mute and hand it over to Audrey.
Hi, everybody. You just someone nod so that they can hear me. Yeah, good. All right. So I I know you all know me now, I think, but I'm a psychologist. I've been at NIH for a long time, and more to come about that. But right now, I'm just going to review where we are with this project. I'm going to talk about the Vigilance study, which is, I don't even understand what that name is, but it was a name for the natural history study that, well, 2 different drug companies actually ended up sponsoring. That's over, and that any day now, hopefully, the paper that I'm showing you is going to be published. But I'm doing it in a different way, because now what I want to be doing is talking much more about the measures as they relate to the outcome set, and especially the 5 we call neurodevelopmental outcomes that we're focusing on in this grant, and just really bring out some of the issues that we had with the study, and then we're going to introduce this idea of the literature review that we did, because we're just trying in different ways to get at the understanding of what CTD needs and GAMT, but what we've learned from CTD already about measures that we have used for these outcomes, what the rest of the world is doing in trials, because that's what our goal is, and then helping get towards what we're getting to, which is a survey and more formal input from you all about the needs of the group. I know we've done the research jam, we've done other things to start to get at this, but we're just trying to pick at it in different ways so that we're all sort of on the same page with where the field is and what the issues are. So just as a reminder, all the work done in the first grant, which is now actually, I don't know if the publication's actually out yet, but it's accepted, showing this whole process that led to the decision, the consensus of the 8 outcomes. So adaptive functioning, which a focus on daily living skills, which is really important, we'll get to. Cognitive functioning, which is really hard to define in the end, but it's really about development of cognitive skills and being able to show that. Emotion dysregulation, which seems really like the easiest thing to define, but is really actually quite difficult, because it's about not being able to hold together your emotions and that affecting you, and that can have a lot of different manifestations and effects. Expressive communication, which I think we all get, which is being able to express yourself communicatively with words or other ways. Fine motor functions, and that's all I'll say. But I just gave a little bit of a maybe tease to what the first activity we're going to do. And then next slide. Okay, so then this is just what's on the website about where we are. Where are we? We're still in July, thank goodness. So we're basically smack dab in the middle of this. And so, like I said, we're trying to gear up and get everybody like on the same page so that we can make the most use of the caregiver community survey that we're going to be putting out soon, having done all this work, including the review that we're going to talk about. Next. Okay, so now that I gave the teaser, Beth, you're going to take over? Yeah.
Yeah, would it be possible for me to just be able to share my screen? Thank you. So, hi everyone, I'm Beth Potter and I've met many of you before, mostly through the first project, and I'm going to talk a little bit about the literature review. But first, we have this activity that we wanted to ask everyone to do. So this is a word cloud. Um, and I'm actually just going to explain it by going to the very first one here. If you are able to do so, and you could go to the website wooclap.com on your phone or on your computer and just type in that code. You'll only have to type it in once, and then we have 5 questions, one for each of those core knowledge.
I only see like a little sliver. Does anybody else have that problem? Yeah. Some reason we're just seeing a white and black.
Okay, hang on a second. Let me just make sure that it might be because I moved my screen there. Can you
Yeah,
see
no,
it?
that's perfect.
Okay. So if everyone can go to that site, you'll kind of go separately, and then we should be able to see your answers to the question, what would change look like for you as a caregiver in the domain of adaptive functioning or daily living skills? And you can answer as many times as you want. You can just put in words or phrases that come to mind.
Do you want the website in the chat
Yeah, the
or
website is the
yeah,
website in the chat. Yep, I think the website is in
I,
the chat. Thank you. Yeah.
I'm doing that. Yeah, I didn't know if she wanted the
Okay.
actual questions or
Thanks.
not.
Nope, just the website. Okay, got some answers popping up.
Well, maybe people should hide to not look at the screen with the answers while they're doing it. I don't know.
Look at your browser.
Mhm.
Well, the point is don't let when anyone else has influences you, but of course it will, so don't look. So, and Beth, are people allowed to put in more than one thing?
Yep, they can put in more than one thing
Okay,
if they want.
okay. But we are going to give a time limit or else, we could be here for 3 months.
Yeah, we have 5 of these, so we'll give people, I know it takes a minute on this first one to kind of get to the website and figure out what you want to do.
Yeah.
Maybe we'll just go for another like 10 seconds or so.
So we're not saying to put everything. We're just saying to put what the first things that come to your mind. Because
Yeah, what you think is most important or what comes to mind. Okay, we ready to go to the next one? And it should just come up for you if you're still on the website, like on your phone or on your browser. So now we're asking what would change look like for you in the domain of cognitive functioning? Oh, these ones are kind of showing up differently. That's okay.
I guess the only definition what we'll give as you're talking about this is like, it requires thinking or using cognitive skills. I know.
It changed.
Okay, I'm ready to go to the next one. Whoops. Did I stop sharing? A
Yes.
bit
Yeah.
clunky. Okay. Now we're moving on to emotional dysregulation.
Beth, and these get saved?
Yes, yeah.
Good.
I'm not sure why they're not showing up in color anymore. I must have clicked on something, but hopefully we still
No, it
get
looks good.
I
It
get
looks
the
good.
point. Yeah. Lots of different answers for this one. Okay, ready? Move on to expressive communication.
I'll just remind you to just try to be specific. I know it's not easy.
Andrea is saying this is too fast. Sorry, someone in the chat is saying this is too fast.
Okay, thanks, Heidi. So we'll leave this one up a bit longer is what you mean. Okay.
Well, and I'll just say, this is what we're going to put in the survey in a lot of different ways, and we're going to give you all the time in the world in the survey. This is literally just to get for audience participation right now, not audience, your participation, just to be thinking. And it's like a little pretest, but this is not what we're going to use to give the FDA to say. This is just for this moment.
I think this is why it wasn't showing up as a cloud there. Okay.
Oh, now it's
I
getting
just
fancy.
realized how to make it to turn into a cloud again. I don't know how I did that wrong, but there we go. The cloud kind of shows you sort of what the most common things are that people are saying too. So it's kind of interesting. Okay, are we ready?
And again, the point of this is so then now just think about this all the time.
Yeah.
Or not all the time, but
Okay. I'll move on. I think this is the last one. So now we're on fine motor function. Mm. Okay. Ready? I think we'll move on. Okay, I'm going to stop sharing and turn things back over to you, Audrey.
wait, is somebody gonna put the slides back? I mean,
Yeah.
I would say, I mean, I know we've talked about like more formal feedback after these sessions, but I would just say, like, encourage everybody to just like take notes after these sessions and what you're thinking. And I mean, they can email them to us or just hold them, because I think thoughts are going to keep changing, as we go through this process. But what this brought up for you, what we didn't ask about here, that's important. I think we're just really, really wanting this to be very, the idea is just to continue to evolve all of our thinking about these things. Okay, So now I'm going to go through and just remind everybody what we did in the study and some of the issues that came up specifically about measuring these things. So next. So the idea again is that this whole roadmap for creating and validating and using outcome measures in trials, the reason why we did the study is, I've showed you this before, is that you have to learn about the natural history of the condition in order to understand what concepts are of interest and most important. We did that simultaneously to you all developing the core outcome set, and we do think that we're in agreement about what's important. And then now we're able to say, okay, well, in these areas, this is what's going on with these kids. Again, it was 2 years, which is still in my mind a little bit of a snapshot, right? Because development is over all of life. So, okay. So next. And so what we did, and again, at the time, I think, I don't know what the numbers are, but 50 was a lot at the time. I mean, but 50 is not a lot when you think about wanting to generalize this to everybody. And what we did was we did every 2 months caregiver, and then every 6 months over 2 years, kids came in. Now, very unfortunately, we had this little thing called the COVID pandemic right in the middle of the study, which made us have to pivot quickly to making it all telehealth for a little bit. And you'll see in a minute, the drop off was not good. But the goal was to enhance our understanding of symptoms and developmental course of people living with CCD, exactly as we're talking about. Next. So this is the kids, and it's just important to see how old they were. And so we really did have a pretty young sample, very much most were 12 or younger. We had a few adults, but very, very young group generally. And then we just put in here, Dr. Miller is very interested in, we all are, in the time to diagnosis, and you can see that there was quite a lag for some people. Next. And then this is what we got. So we screened 52, we got 50 enrolled. But then when we got to the end of people who completed 2 years of the study, we only got to 29. So 21 people were lost to follow-up altogether. And so 29 completed the study in one way or the other. And so this is where you can see here, I mean, again, a 2-year study, it's very expensive, it's very time consuming, it's unbelievable how much participation we got. But when you really think about the lifespan and understanding of natural history of CTD, it's not so much. It's like up to 2 years in 30 people that were mostly pretty young. So I think there's almost nothing we can say about adulthood in here, and there's not too much. The data gets pretty slim even for adolescents. So just thinking about that. Next. All right, so this is, I think, a pretty cool figure that shows that first of all, it shows how many kids ended up doing each of these milestones. So pretty much 100% were walking. And then it shows about when they developed those skills. So it's showing that about 75% of kids developed single words, meaning that 25% didn't. But remember, some of the kids were less than 5 in the study. So it is definitely possible that they will develop words, but weren't young enough given the delays we see. But then you can see, and so, almost every kid in the study should have developed all these skills. So, the delays are very significant. And then we get to things like speaking in sentences and fully speaking in sentences. I mean, so I think this just gives us such a good, can you hear me? Yeah, I think it's going to switch to my microphone if it hasn't already. It gives you such a good sort of visual of that, we're at like, definitely less than 25% of kids having achieved toilet training, and, about a quarter talking in sentences. We need a snapshot. We need every kid to be individual. And some of you have kids that are fully talking and toilet trained, and we understand that heterogeneity is there. But if we just want to sort of summarize the condition, it can tell us that, development of those skills is pretty delayed. And that it's a significant percentage of kids are not doing these things in the end. So I think this is something that we could take, to anyone involved in the drug development to really help think about just one course way of getting to measures. Then next, but we didn't know this, by the way, going in. We had one report of 100 kids that was based on retrospective just patient reports. So we had to learn this. Now, this is the table that we're not going to go through in detail in every way, but which we put in the paper, which showed our learnings about the measures that we used, and that some measures just did not work at all. So any of you who were involved in the study know that we tried to do some EEG work using something called Cognizant, which was a company. We had to stop it altogether because we just didn't have enough kids who were able to. This is not overnight EEG for seizures. This was a different type of EEG that we were doing sort of in the middle of the day, trying to get kids to sit and listen to things while we were doing it. We had to discontinue that. There are other things we discontinued, like a measure of ADHD and a parent stress measure, not because those things were not important, but because the measures just didn't capture the skills well. And we got that feedback from parents. And so like the measure of ADHD was not developed for kids who have a significant amount of kids who aren't talking and aren't able to do other things like it asked about homework and things that, we know a lot of these kids are not doing. So it's just not fair to ask those questions. So those are things that we discontinued. And then even in something like cognition, which is further up, we used a Wechsler test, which is like a test that is used, in schools for a typically developing population. And we did include it, but we switched the test at the end because I think it was only 3 kids out of the 50 that were able to get that measure. And what I mean by get that measure, I mean do enough on it that we could actually obtain a score. And even and even a measure of expressive language, which was a measure of vocabulary, less than half were able to do that because it required being able to name a bunch of objects. And as we saw, a significant percent of kids were not using words. Now, these tests are not validated for using AAC, but we did try to use it in the situation, and it didn't substantially increase the numbers for this, but we're going to continue to think about ways that we can get alternative output. I think those are pretty much the examples I wanted to give. But again, there's a bunch of measures that we did use and got lots of data on, so we want to focus on that too. So now I don't know how much time I have, but I'm just going to go really quickly now through some slides that just show the data. And then, and I know you've seen this before, but when we think about intellectual disability, from just IQ, we were able to get at that. Again, the ones in red are the WASI that I said there were the few that we could get from that. The others was a test called the Mullen, which is developed for kids younger than 6, but we gave it to many kids that were older than that, and it allowed us to get scores. And then the adaptive behavior, which we could get on everybody because that's the parent interview, we have lots of data on that. And then this is what it looks like in the kids who did it 2 or 3 times, just to see how it changed or didn't change so much. Next. And then this is just within cognition. We want to really make sure that we look at both verbal and nonverbal separately, because the nonverbal shouldn't require expressive language. It's like puzzles and patterns and things like that. So we do think we're going to see differences there, and we did, because we want to make sure that we're not only requiring expressive language and looking at the differences there. Next. And then this just shows you what I just talked about, which is that so I guess that's the average age, but so the Mullen was used, that's the red in kids that were much older than 5. So it was used what we call out of age range, and there's a lot of it's great that we could use it, but there's limitations because you don't get the same kind of scores, and it's not always totally appropriate for older kids based on some of the items and toys and things that are included. Next. And then this is within adaptive behavior. And so adaptive behavior includes daily living, which is going to be the focus of the outcome measure of the outcome set. But it also includes other things. And so we wanted to just, look at what it looks like in communication and socialization also. And so just telling you that we have these scores. Next. And then we're not going to get into this now, and I've talked about it before, but we've got this idea of standard scores, which are the scores compared to kids that exact age. And we're not going to do the details here, but you can just see on the left, if you look at the bottom where it says 1, we see a lot of 1s. We see a lot of kids that's the floor. That's the lowest score you can get. And when you have that, number one, if you're doing that over time, and they stay a 1, you're not going to see change. But also, it's not too helpful. So these other kind of scores that I've talked about, which are growth scale values, do not compare you to anybody except for yourself over time. And then the red dotted line is what you would see in typical development of improvement in scores. And then you can just see then where kids are falling in their growth compared to what we would expect of typical kids for the growth, not for where they are at one point in time. And as you can see, there's a little bit of scores at the bottom, but much, much, much less on this. And this is why we think this measure still is very usable in this population. Next.
Sorry, I'm going to ask a quick question because I
Yeah,
won't be able to find it.
please.
So would you look at this and go, okay, so we see the movement, this is great, and the strongest indicators are the ones that don't have a lot on the floor in these growth scales. Like we can expect that there will be more measurable change in receptive and expressive communication versus written, for example.
Yes,
Yeah.
absolutely. But I think the other thing is, prioritizing based on everything you've done. And so the group prioritized daily living, which includes the domestic, community, and personal. And I think just from seeing the world cloud and having talked to everybody, clearly the daily living skills that people are focusing on are those personal. That the personal is the one, sorry, it's above, not interpersonal, personal. There, right there. Yeah, exactly. That's the one. And you can see almost no floor effect there, which is awesome. And that's where the feeding, the eating, the dressing, and the toileting all are. So I think we can even just focus on that. And that one looks really, really good for what we're trying to do. The domestic are like chores. And even in the real world now, people are not so focused on that. I mean, but it's still important. And then community is like not littering and going out and eating in restaurants. I mean, those are important things too. But I think this group has clearly focused on that, those personal daily living as so. It's good when we have a focus, right? But then, oh, sorry, fine motor is another area that we're gonna, you know, hopefully use, and you can see that's another one where it looks really, really good for, and then of course, expressive communication too. So it's just really important to see that even though I showed you that we've got, you know, a big chunk only in single words and not sentences and even no words, that doesn't mean that they're not doing anything on this, because even just pointing and signing and having sounds gives you scores on this. Okay. All right, I think we can skip this because I've shown them all in scores. This is just another way of showing how it looks over time. And then emotion regulation. So the measure that we thought was sort of showed it the best in the Vigilance study was what we call the aberrant behavior checklist, and it's divided into different areas. And from everything I've heard, it seems like the irritability sort of summed up what we were seeing in the word cloud and the things that are being talked about. So again, I think what you're seeing here is a lot of variability in kids, and you know, those kids who have what irritability, when you see over time, you know, it's not going away, it's staying. So that's just sort of what we can glean from that. Next. And then again, this just shows it in a different way over time, showing that, well, yeah. Next. All right. Turning it to Beth for a minute.
Okay, great. So we'll go to the next slide. And so we thought we would just give everyone an update on the literature review that we've been doing, and just some of the methods that we've used and some early findings. So what we're doing is called a scoping review, which is basically a review of the literature. So a review of published studies. And it's called a scoping review. Sometimes we'll talk about a systematic review, and that's where you're trying to summarize the findings of studies, all on the same topic. This is a scoping review, and so we're not so much interested in the findings of other trials. We're interested in what those trials have focused on, and in particular, what they've measured in relation to those kind of 5 core outcomes. And so the scoping review involves systematic searching, so looking for the studies that we're interested in, selecting the ones that are the most relevant, and then synthesizing them, which is basically just describing them. And so for this scoping review, we're focused on those 5 core outcomes that we want to kind of look at in more detail. And here what we're doing is looking at how trials have measured these outcomes. So we're looking at clinical trials, not just for CTD and GAMT, but for related health conditions, so for other neurodevelopmental conditions. And we want to know how, you know, where have these outcomes been measured, and then what measurement tools, so what questionnaires, scales, assessments, and things like that have been used. And then we'll look at what are the properties of some of those tools, some of which you've already seen there with the Vigilance study. And so we're interested in a subset of 5 core outcomes for the first project. So the ones that are neurodevelopmental in nature. So the adaptive functioning, cognitive functioning, emotional dysregulation, expressive communication, and fine motor. And we're using a 4-step process. So the first 2 steps are finished. So the first step was to just look for published articles, published trials in the literature. The second step was to screen. So when you do this kind of a study, what you are doing initially is casting a really broad net. We have to kind of identify a whole bunch of trials that might be relevant, and then we use kind of a systematic approach to figure out which ones actually meet our criteria and that are of interest to the study. And then we're taking the information that we want from each of those trials, and we'll analyze and interpret it. So we'll go to the next slide. And so just a quick overview of that first step, which is looking for the published trials. And so for this step, we worked with a specialist librarian to develop a search strategy. And so here we're looking at what are called bibliographic databases. So you've seen some of these probably, like PubMed has Medline and so on. But these are basically just these large databases that have information about published research articles that have been peer reviewed and published. And so we need a specialist librarian to do this kind of search because those different databases, they kind of catalog and tag the different articles in different ways. And so you need to know a kind of vocabulary to be able to identify which search terms you're going to use. So for this study, we looked in 3 databases, Medline, another database of the medical literature called Embase, and then a third database called Cochrane Central. That's a database that tries to find clinical trials. So we were looking for clinical trials for children with neurodevelopmental disorders or intellectual disability. We published our scoping review protocol online. So the protocol is the plan for how that scoping review study will unfold. And this is typically what people will do with a scoping review or a systematic review. And you want to publish your protocol before you get too far into the study, because that can help us really guide what decisions we're making. And it also tells other people what we're doing and ensures that we kind of document any changes that we make to the plan along the way. And so there's a QR code there. This may not be of interest to you, but if it is, that just shows where you can find the protocol for this particular review. Okay, next slide. So the next step of this project was to screen the articles that we found. And the purpose of this step is basically, we know that we're looking for clinical trials. We know that we want clinical trials that include children, where some of the children have intellectual disability. In our case, we decided that we wanted to really focus on clinical trials of drugs, natural health products, and devices, because those are the kinds of clinical trials, those are the sort of interventions that are going to eventually need to go through the FDA and other regulators and policy decision makers. And so it might be the most important to kind of think about what measures they're using. And then we wanted studies that were measuring at least one of those 5 core outcomes. So we had that, those are in the table, our sort of inclusion criteria. And then we have our wide kind of list of studies. So we found over 8,000 citations from our search strategy that could be relevant, but most of them probably aren't. And so then we've used a systematic kind of process to winnow it down so that we get just the articles that are of most interest to us. So you can see on the right there, there's 2 steps. At the first step, we look just at the titles and the abstract, so those short summaries of the articles. And then at the second step, we're kind of reading through the whole article. So next slide. So this is probably more detail than you want about the screening, but at the first step where we're looking at the title and the abstract, we're taking those criteria for being included in the review and we're going through them in kind of a systematic fashion, which is what those questions show at the bottom there. So you're answering, was this actually a primary research study? If not, let's get rid of it. This isn't something we're interested in. If it is, let's move on to the second question and look at who's in the study. The third question, which looks at what interventions were studied. The fourth question, which is whether or not the trial focused on children with intellectual disability, and so on. You'll notice here that we're interested in outcomes and outcome measures, but we left outcomes out of this first screening stage because it's really difficult from just the title and the abstract of an article to know what all the outcomes are that have been measured. So next slide. So then once we've kind of done that title abstract screen, we go to the second stage where we actually have to read the whole article for those articles that still might be relevant to the research. And now we're actually going through really systematically and trying to find answers to all of the questions. And here is where the outcomes come into play. So what might be helpful to think about here, and just thinking about what Audrey just presented with the Vigilant study and also that word cloud exercise. These were some of the words and phrases that we gave to the people who were helping us to screen through these articles to look for, to see whether these trials were measuring expressive communication, fine motor function, emotional dysregulation, cognitive functioning, and adaptive functioning. So they were looking for outcomes and outcome measures that might relate to these concepts. And we also gave them some lists of some of the most commonly used measures of these outcomes as an additional way to kind of help find the trials that that included these measures. Next slide. Audrey, jump in if you need to, if you want to correct or add anything here. And so this is really tiny and maybe not that important to everyone here, but just to let you know, this is kind of how you track a project, a literature review like this, to sort of see what happens. So we kind of want to know, with all of those over 8,000 citations, what happened to all of them. So we first kind of have our articles from each database. We remove the ones that are duplicated. Then they kind of go through this systematic screening steps. On the right-hand side of that figure, we found a systematic review that was kind of similar, had some similar goals. So we looked at all the articles that they found to see if they were relevant. And then at the end of the day, we had, this is actually too small for me to see on my screen, 131 articles in the overall that met the criteria for this study, and a related study that we were collaborating on that was looking at the same articles but different questions. And then 90 of those were specifically clinical trials published since 2019 in children with intellectual disability that were evaluating drugs, devices, or supplements, and that measured one of those 5 outcomes. So that's kind of now our sort of data set for the rest of the review, those 90 articles. So next slide. So this is where we are now. We're taking information from each of these 90 articles. We're looking at things like what conditions or diagnoses were included in these trials, what were the specific interventions, some information about the trial designs, and so on. But then, of course, what we're really focusing on are the outcomes. So we want to know what outcome measures were included in these trials that relate to any of our 5 outcome domains of interest. We want to know what the specific measurement tools were. So for example, did they use was it the Vineland? Was it the Baileys, and so on? We're looking at whether they used kind of the whole measure or did they use particular subscales. We're trying to look at how the authors of these trials describe their outcomes. One of the things that we're learning from the study is that there's just a lot of variability in how trialists really report on what they're trying to measure. So that's kind of an interesting and challenging tasks that we've been doing. And then we're also looking at whether outcomes are the primary outcome for the trial. That's really important because the primary outcome will be the outcome that that the sort of sample size is based on, and that's the outcome that's considered to be most important in a submission, for example, to the FDA or to another policy decision maker with the findings of the trial. So we also want to know, when were these outcomes used as primary outcomes, and when were they kind of additional or secondary outcomes? And so we're still collecting some additional information. So next slide. So this is where we are now. So from the 90 trials, this is a little bit of information about them. Most of the trial reports are not actually saying which trial phase they're in. We can fill some of that in by looking at some other information from them. You can see here, there's about sort of equal numbers that were funded by industry or that were non-industry funded trials. Just a slight majority were randomized trials. So some of these would be like single arm, like everyone receiving the treatment, or another design. 33 out of the 90 had a placebo comparison. The average sample size was close to 50 participants, and the average trial length was over a year, so 57 weeks. And then you can see at the bottom there some of the most common conditions that the diagnoses of the participants, the children who participated in these trials. Okay, I think I'm turning things back over to you, Audrey, to talk about the measures.
Okay, so I'm not sure if it makes us feel good or bad that this list of the most commonly used measures happens to be basically the same list that we used in the Vigilance study, more or less. So again, these are only measures in the areas of the 5 common outcomes that this group decided on. But as you can see, the Vineland was used most frequently. And as for adaptive functioning, and includes expressive communication, like we talked about, in fine motor. And then under cognition, the Bailey, which is similar to the Mullen, but a little more updated and better because it has growth scale values, was used in a lot of studies. And then again, a lot of people were interested in emotion dysregulation, and so that an aberrant behavior checklist and a child behavior checklist are two measures that get at that. And then the brief is a measure that we did not use in Vigilant, similar to what I mentioned with the ADHD scale. It just was never developed for people who have intellectual disability, but it's still being used in these trials, which is very interesting and concerning. And then a visual analog scale is a way of individualizing, where you would just rate where a child falls by looking at a scale. And so it's more of a method than a specific measure that we can talk more about. Next. And so again, going based on the different areas, adaptive functioning, the others are basically just different ways of getting at it. I think we can keep going because I know we're gonna have time. Next. Yeah, so again, whether it's the Vineland or the ABAS, these measures either are questionnaires or interviews. The ABAS is only a questionnaire, and then it asks, questions that you're very familiar with. Can do these things. And in general, they're asking, can't do them at all, can do them either with some help or sometimes, or all on their own independently. And that's really, the idea of the skill building, both emerging and then independence in these skills. Next. So then in cognition, the reason why there are so many measures, well, some of it is like, are we talking about, a Toyota or Honda? It's just different companies developing similar measures. But the other reason is because they're different age groups and different functioning levels. And that is the harder thing to overcome, is because, as you all know, we expect babies and very young children to do different things. We expect them to be playing more with toys. We expect them to be, in a pre-verbal state. And then we expect older kids and adults to be doing very different things. So we would use different tools. We wouldn't use toys as much. And we just expect different things. And so even if we had the same measure, we would still need to change the tasks. And so this is just like an absolute dilemma that we have in the field, is that getting a measure that would cut across different ages and levels of functioning is something we do not have for a direct measure of cognition. So these are all measures that the child is sitting and doing. Next. Yeah, so these are just examples. And as you can see, these are ones, well, the Bailey, we actually did try at the end of the Vigilant study, but we only got a little bit of data. Next. And then in expressive communication. So these are a mix. So the Vineland, as we saw, is the parent report of what the child is doing in that area. And then the rest of them are measures that require the child to sit and do tasks, either talk or give vocabulary or point to pictures so it's a mix for this. And then there's some other measures that have been used. None of these are measures that are good at incorporating AAC or kids who don't have very much output, and that is a problem. But there are some measures being worked on right now that weren't even available when we did that study. Next. Yeah, so the Mullen, again, is a measure that in total, we talk about as cognitive development, but includes expressive language. And like I said, has very early items like, does the child laugh, which, you know, babies do after just a few months, to, you know, 2-word phrases, all the way to full sentences. And these are just examples. Next. And we've talked about the Vineland in a lot of different ways, and these are just some examples of, like I said, early items, like crying, believe it or not, as we all know, is part of expressive communication. So even for kids who are nonverbal, doing that, and then, you know, getting at different markers of language development with speech, of using, you know, being able to name just 10 things to, you know, much more complicated grammar, and all the way to sort of being able to give someone directions about how to get to the mall as a really high level item. Next. And then fine motor, again, you're going to see some of these same measures actually have subtests or domains for specific things. So the Bailey again is on here, and so is the Vineland. And then there's some other specific tests that really, you know, the pegboard is literally picking up pegs and putting them in holes and seeing how fast you can do it. And then others are measures that ask for a lot of different fine motor tasks, like being able to draw, being able to string beads, things like that. Next. Yeah, I think, and so again, this is the Bailey, and you can see here some of the exact items that it asked you to do. I think we're maybe at the end here. Oh, right, I know. I think I personally forgot about this domain. Right, so so emotion dysregulation has, again, the measure we've been talking about, the aberrant behavior checklist, which has that irritability subscale, and then a few other measures. I mean, some studies are looking specifically at certain symptoms like anxiety. That's the pediatric anxiety rating scale, and the Adams is specific to anxiety. Next. And again, examples of these items, and these are all questionnaires. These are all, we're never basing these things based on a child, although those measures do exist, where you would actually play with a kid for a while and measure emotion dysregulation. They exist, but they haven't been used in trials. It's really all been questionnaires with like, over the last 2 weeks, how's your child been doing, and blah, blah, blah. There's some interesting developments of measures that may be more iPad based or iPhone based, where you can do it every day. Some things that people are working on, but those are not validated yet. So these are the kind of measures we've got now. Next. And then I think we're just, that was it for what we were going to present, right, Beth? Yeah.
Yeah, that's right.
We've already talked about the research gem.
Okay, thank you. Do we have like 2 minutes for questions?
Yeah.
May I ask, is the vigilance study now officially finished, or is there somehow longer follow-up for those 29 patients that were still in it, or are there any other plans to do something similar?
Great question. I can tell you that study, unfortunately, is absolutely shut right now. It, as I said, it went through. It was one drug company and then another drug company, and that second drug company decided to end it. And so right now there isn't funding to continue it, but that's something that I know. I don't know if Heidi wants to talk more about that.
I mean, in the context of MRS study, maybe.
Sure. Yeah. I mean, just about, I mean, yeah, I think the foundation, I just don't want to speak for, I've been thinking about other ways of collecting data, including the registry, where we can just keep on collecting at least some data as, you know, more and more kids are getting identified. And I think the registry is a way you can sort of complement or supplement what's been done there.
Yeah,
For-
I was
Yeah.
thinking this. I was thinking the same actually, because for example, my son has had like 3 Bailey tests in the past year. You know, if we gather all the data from different patients, that could be really useful if we use standardized tests anyway
Yeah,
in clinical practice.
yeah.
Yeah, I think the goal with the registry and this project is to look at, okay, now how can we be capturing some of the data to support our core outcome set so that there is an expanded natural history available when we go to a clinical trial. And as everyone knows, there's no natural history for GAMT. So the more we can build in the registry, the better. And then with we haven't really talked about this in a bit with the whole group, but the subject matter expert group that we've assembled on MRS is looking at of a study to, it's almost a little mini natural history study where we collect some labs and do cognitive assessments, and making that cognitive assessment compatible with all of this prior data would be fantastic. And I would bet that some of these kiddos would be some of the same kiddos that had participated in Vigilon. And there are things in the back end as far as like assigning a clinical research ID that the parents would opt in on, and then getting some of this data from NIH, which is something that we have been talking about and have been told is feasible. A couple of years ago, there's a little bit of a moratorium to access that data, but then once we were able to, we could string a lot of this together, especially if we're strategic in what we measure in trials, such as if we were able to get the funding to do an MRS study. So yeah, like, and I think this, the literature review, it just all kind of builds upon what we've done so far and what we should do going forward. And we're thinking the same, Micah. Yeah. Do you want to add anything to that, Audrey or Beth? I mean, we do have right now a kind of an open bucket survey in the registry, which is medical records. But, I don't like to encourage people to do the work and upload records until I'm like, we're going to make use of this. And we're making use of like the genetic report when you upload it. And we can make use of MRS results and blood results and diagnostic reports in reclassifying your variants. And then when we get to that point where we could sure use some Bailey scores, we would be promoting that in the community and saying, hey, upload this if you have it. But maybe this is a good conversation to be having to alert parents, more and more, keep your records, don't lose track of them, because there's a good chance that we'll have studies where we ask for those.
I guess I would just add that, I mean, I think the cool thing about what we're doing here is that the numbers that you got from those Baileys are really important, but your experience, I hope if you were able to watch or be part of, or even see the report from that, is actually like what we're talking about here, which is we never ever do is talk about what was it like, was it hard? Do you feel like you got the best? And I know the answer is no, but what could we do differently? Because that's where we're actually having time to think about this in this grant, which we just very little do. So it's more like the process of it, and are we missing something when we're only giving that? And again, I know we are, but like, just thinking about that. And then I'm going to quickly answer Andrew's question, and then we'll move on, right? I can't see the bottom part, but let me just see. And the relevance, this might having parents ask clinicians to assist them to collect. So, yeah. So the answer to the question is, would continuing to use these tools like the Bailey or tools that are outside of age range be useful, worthwhile for kids even beyond the age of 18 into adulthood? And the answer is absolutely. I mean, I have given measures out of age range to people in their 70s. So there's no limit. Once you're doing it out of age range, there's no limit in age that you can do them for. And it's just, I think that the underneath that question is, you know, is it important to keep getting data from adults? And the answer is absolutely. We need to know if skills are preserved, if they're maintained. I've seen adults absolutely develop new skills, you know, so what's happening in adulthood.
Okay, we have one more quick question and then we'll get to
Yep.
Jacob so he has enough time. The question was, how long will it take to validate the studies currently being developed?
How long will it take to validate the studies? Maybe the measures. Yeah, that is a really, really good question. And my answer is terrible, which is that it's continual validation of these things. And you have to validate them in each population you want to work on. So that's why we need to have more studies where we're actually testing kids with CTD, because we can't assume that if you're validating it for Rett or something else, that it would be validated for CTD. So it's continual is my answer to that.